Good day, and thank you for joining us today as we present along with our friends from the Council for Federal Cannabis Regulation. Today, we're welcoming 3 special guests to discuss cannabis science, addiction, and misinformation. Before we begin, we wanted to cover a few housekeeping items. If you have any questions during the webcast, you can submit them through the Q&A widget at the bottom of your screen. Your questions will only be seen by the presenters. We really encourage this audience participation because a lot of you have a lot of knowledge to share, and this makes the webinar more interactive. You can also see answers to common technical issues located in the help widget at the bottom of your screen. And with that out of the way, I'm Jack Jacobson, and I'm an advisor at Thompson Coburn, and I'm one of the Council for Federal Cannabis Regulations advisors. To start us off today, I'd like to welcome Deborah Johnson. Deborah?
Good afternoon, everyone. I'm Deborah Johnson. I'm the Executive Director for Council for Federal Cannabis Regulation. We're all excited about today's guests and the topic, so let's get started. And I'll reiterate what Jack just said. We really do appreciate a lot of questions and your participation in the webinar today. We'll try to get to as many as possible. Please use that Q&A widget to ask your questions. There's a chat function as well, but use the Q&A widget to ask the questions of the presenters. So to kick this off, I'd like to introduce some of our speakers. We start with Dr. Tiffany Buckley. Dr. Buckley established the first comprehensive clinical pharmacy services in 8 inpatient units at Clifton T. Perkins Hospital Center. Dr. Buckley, would you please continue introducing yourself?
Hello, everyone. It's such a pleasure to be here today. I am a board-certified psychiatric pharmacist, and I also have the pleasure of working at the University of Maryland School of Pharmacy in our first Master's in Medical Cannabis program. So I administer various courses within that curriculum. So I'm constantly developing new courses and teaching people about cannabis.
We're thrilled to have you with us, Dr. Buckley. Thank you. I'd also like to introduce Maureen Fitzpatrick. You do not see her on video today, but she is participating in this panel. She is a family nurse practitioner at Fells Point Cannabis Docs. Ms. Fitzpatrick, will you please continue introducing yourself? Maureen, we are not hearing you. If you perhaps pressed your mute button.
Hi, good afternoon. I'm a nurse practitioner here at Fells Point Cannabis Docs. We're a specialty clinic that was established 4 years ago specifically with the intention of trying to provide high-level care of patients who would like to pursue the use of medical marijuana. And prior to this, I'd worked for about 10 years for the VA as a primary care provider. And I have previous experience in sexual health and research, both at Shepherd Pratt and Johns Hopkins.
Thank you. We know you've been providing care for populations since 1995, so we appreciate you bringing that wealth of knowledge to the discussion today. And finally, we have Dr. Samoon Ahmad. Dr. Ahmad has been a practicing clinician for over 30 years, and he recently retired from his role as unit chief of the inpatient unit at Bellevue Hospital. Dr. Ahmad, will you please share more?
Thank you. It's a pleasure to be here, and thank you for the introduction. I am a clinical professor in psychiatry at NYU Grossman School of Medicine, and I've been at NYU and Bellevue Hospital for the last 30 years, serving the indigent population of inner city New York. And this population, other than the severe persistent mental illness, I would say 70 to 80% struggle with dual diagnosis with substance use. And as a physician, as a psychiatrist, and going back, I think, to the scheduling issues, we recognized, I think, early on that our training was a little bit skewed and only understood that people with mental illness who were struggling with substance use and how that exacerbated these conditions, and cannabis was one of those. And I've struggled with sort of trying to fit this in terms of its therapeutic value and trying to educate myself and teach myself. And along that journey, I wrote the textbook on medical marijuana, which was just as I think, a way to educate myself as well as my fellow clinicians. So my research is in the clinical area, as well as seeing patients who are struggling with this, looking at a therapeutic value, and people seeing where the necessity is and how to weigh the risks and benefits of this plant.
Fantastic. And thank you to all of you. I'm sure our audience can tell that we recruited you for this conversation, which is around cannabis hype, separating the harm from health. So we're trying to understand, as cannabis becomes mainstream, how much cannabis might be too much. So my first question to the panel, and we'll start with Tiffany, is what are the components of cannabis and how does that compare to traditional medicine? Tiffany, if you're speaking, you're on mute.
Why don't we let Dr. Ahmad jump in?
Sure, I'll jump in. No worries about it.
Oh, great. I just got my sound.
Okay. Tiffany, go ahead. I was just going to.
No worries. So cannabis is a plant that has been used for centuries. The first recorded texts of that are from ancient Chinese texts, and it was used medicinally as well as recreationally. So cannabis is very complex. It contains over 500 different components. Some, which you might have heard of the most, are the phytocannabinoids like THC, as well as CBD. We also have terpenes, which give cannabis its unique smell, and flavonoids, which are responsible for that really unique color of cannabis. It's really important to note that cannabis is really different than traditional medicine. It's different than just taking a Tylenol, for instance. The active ingredient in Tylenol is acetaminophen. It's a small molecule, while cannabis is so complex and has all these different components. Different ways that we grow it can also influence the components that we're seeing in the cannabis and the different strengths and concentrations. Did you want to jump on that, Dr. Mahmood?
I think you very well elaborated on that. And I think one of the distinguishing features, that we talk about, even though there are 500 compounds and 140 phytocannabinoids, I think is the distinction that for the two most prevalent ones, the THC and CBD, and that is the distinguishing point, the concentration between hemp and marijuana, because by dry weight, if the concentration is more than 0.3% of THC, it becomes marijuana, versus if it's less than then, and it becomes hemp. But I think within the past 60 years or so, as you mentioned, 140 compounds that are more or less unique to cannabis have been discovered. And I think, as you were talking about it, there's in commercial products, I think the issue is there's a significant concentration of all of the other aspects of the plant compared to just one or the other. Furthermore, they don't just have therapeutic value when administered in isolation, because they seem to modify the effects of other phytocannabinoids when they're taken together. And I think perhaps the best known example is how cannabidiol, which is CBD, can attenuate some of the intoxicating effects of THC. And I think, as you had mentioned also, about dozens of flavonoids and I would say about 100 or so terpenes, we know that different concentrations of these compounds are responsible for these unique effects. And we also recognize that these compounds also can modify subjective experience, I think, of the cannabis intoxication also. Because if you look at the terpenes like pinene or like CBD, they also have been shown to mitigate the effects of the THC intoxicating, like concentration of another terpene, which is myrcene, which is the most common one, in fact, available in cannabis, is also responsible to what is conveniently called as the couch lock when combined with THC. However, myrcene by itself, which is like in mangoes or lemongrass, doesn't cause couch lock. You can eat as many mangoes as you like, but that's not going to have that. But I think the most important is when we look at these compounds, is what we call is the synergy between the THC, the CBD, the cannabinoids, the terpenes, the flavonoids, is the entourage effect. And I think as we move forward in science and we do more and more studies, I think, in my opinion, it would be the relative changes in concentrations and up and down. I tell people that sometimes if you look at this musical component called the equalizer, which increases the bass and the treble, you can think of actually the plant of the cannabis with all of these different ratios and concentrations. And just altering those can have potential extreme therapeutic benefits versus looking at some of the intoxication or other adverse effects.
And
It
Maureen,
is important to note, though, that a lot of the information about terpenes and flavonoids and all the effects that those have within cannabis, that still needs to be determined a little bit more. The evidence is still very, very new in that area, but there are studies coming out on it every day. So we can kind of put our finger on more what's going on with the plant.
And we'll turn to Maureen for the next question. How does the whole plant cannabis compare to commercially available cannabinoid products?
Well, that's interesting, and much of what we've already discussed kind of points to the complexity of a whole plant product flower as compared to the products that are available at dispensaries. Now, oftentimes flower is available in various forms, but it's complicated more and more these days because of much of the industry going in the direction of trying to emphasize THC content over other components. We lose a lot when we emphasize just one component because, it is such a synergistic effect that happens between the various terpenes and cannabinoids. I've seen some recent commentary on the fact that is becoming such an issue that there are labs out there that are willing to up-report, if you will, the strength, the THC strength of flower that gets sent to them for testing, such that it's being misrepresented just to be able to sell it more. The thinking being that the customers are looking for something that's strictly high THC, but we lose so much if we focus entirely on THC. So many other compounds have reasonably good data, like very good data, in fact, on, for example, CBD and treatment of anxiety. But it's the synergy that really does the most.
Dr. Buckley, Dr. Ahmood?
Yeah, I think a good point, because I think one of the major obstacles, in my opinion, when looking at what you were just mentioning, that we lose actually so much when we're just talking about one particular compound, is the fact that most of the data and research, and if you have to do research and unfortunately with double-blind studies, you can't take something which has so many different compounds and so many variations. So by nature of how the science studies are done, I think it's skewed that you look at selective molecules, while what they're using is not selective in any way. It's a complete mishmash of so many compounds. So I think it varies from person to person, sample to sample, day to day, and what your source is. And for clinical studies, there's one source, University of Mississippi, from where you're going to get something, which is not what's sold in the dispensaries and stuff. Bartender will give you anything, or whoever you're getting it from. So I think what we see, the clinical effects in people on a day-to-day versus what the science says, that disparity needs to be streamlined. And that's a major struggle of how science looks at only one molecule versus the compound, which has all these variations.
I think it points to the fact that we also are so used to taking a Western medicine approach to drugs in this country, the pharmaceuticals, whereas a product like marijuana really seems to fall more under the heading of an Eastern approach.
But I think also what you just pointed out was extremely important, the ratio or the THC or the concentration, which is what you would find the medicinal value therapeutic versus what the high potency THC, which is trying to be sold. I mean, if you look at only historically, I mean, 1960s, THC is what, 1 to 3%? By 2014, it's 14%. Actually, and it's gone up to 30. And if you look at what we call as shatter or glass or wax, 80 to 90%, which is another story of what some of the psychiatric aspects and issues with that one. So I think I'm not saying that necessarily concentration is bad, because for thousands of years, different regions have used cannabis of all different potencies. But I think as the ratio and concentrations have increased, concentrations of this, we really need to keep that and sort of see who's using what and for what purpose, and particularly even among the age groups, what impact it has.
That's a really good point. And so many of the side effects, when we do see side effects, seem to be related to excess amounts of THC.
Right. I mean, I've seen people who are, especially young adolescents, who present in a completely psychotic state at times, and they have been using 80 to 90%. In fact, I'll share this vignette, interestingly, that, sometimes you see somebody in their 60s or 70s. And when they were back in 1960s and 70s, they were using marijuana, which was 1 to 3%. And then they have sort of just fallen through, have never used it. And now they go to some place, some festival, a music or party, and they say, oh, I'm going to have a joint here. And they smoke, and voila, they were using 2%, and now they're using 15 to 30%. Yeah. And it's like they have such sometimes bizarre effects and all kinds of anxiety and different kinds of panic and even soft psychotic symptoms. And it's like, well, I used to smoke. And the point is, you used to smoke, but not 14 times of where it was.
Yeah, the increased potency is definitely potentially causing some issues. There was recently a systematic review released, which I really like. A systematic review is when researchers take a whole bunch of different studies that are similar and they put them together and they try to kind of see, is there any association going on between these studies? So one was done looking at cannabis, comparing high potency cannabis to lower potency cannabis and looking at outcomes in terms of depression, anxiety, psychosis, as well as cannabis use disorder. And the studies are observational, so that means the researchers just watching a phenomenon happen. There's a lot of variables that aren't controlled, but what they saw was that higher potency concentrations of that cannabis increased psychosis as well as cannabis use disorder. So it's a little more difficult to tell about depression and anxiety. And granted, there are lots of limitations with this study, but I think it's really important for us to know that we need to at least look at that some more, figure out why we're seeing these associations and what's contributing to that, and figuring out what we can do to prevent harm, because we are seeing people have some harmful outcomes with the higher potency cannabis. Now, there are situations where people have positive outcomes, sometimes with chronic pain. They show that there is a benefit with a little bit of a higher potency THC for that, but it's just important for policymakers and consumers to know that the cannabis that is available now is not the cannabis of the 1970s.
No, I think Tiffany, building on the data, I think it's extremely important for the audience to recognize, because what you're saying is from the policy perspective, to look at these things, because knowing your data is extremely important. And there is also analysis done by Mahmoud Al-Soli looking at the ratio of THC to CBD, because CBD tends to negate some of the intoxicating effects of THC. And what they looked at was they compared the 2009 to 2017 of what the sort of ratios have increased. And back in 2009, which is not that actually, the ratio of THC to CBD was 25-1. And in 2017, 105-1. So
Wow.
you can just look at 4 to 5 times, it has gone up. So no matter, I mean, you need to take tons of CBD just to sort of undo some of the effects of the THC, which you are pointing to. And one of the reasons that I think there has been so much backlash of the idea that how young people or other people are becoming psychotic, I think, sometimes you really have to look at not only per se just the plant, but exactly how we are artificially, especially many of the people who are manufacturing and doing this, can make that concentrations and cause some of the problems.
So let me ask on that. When we say problems, with this sort of metamorphosis of THC over time, or the plant as a whole, the flower as a whole over time, can that lead to addiction of cannabis or addictive habits?
So that is still very difficult to say because there are lots of limitations with the cannabis research, which we can talk about in a little bit. I see there's a question about that too. So thank you so much for that. But what we tend to see when you look at the evidence is that there is, with the increased potency of this THC, there is an increase in the chance that someone could potentially become addicted to cannabis just from observational studies that have been done. Back in the day in 1992, some of the data suggests that about 9% of people who utilized cannabis would go on to have some form of dependence. But now we're not necessarily sure what that looks like because of the increases in the potency of cannabis. So there's some interesting research areas there for people who want to try to explore that relationship with potency and dependence even more than it already has been done, because as I kind of touched on before, there's not really that much solid data out there on it.
Right, definitely expanding on that, I think you're right, absolutely. It's a very complex, because I think to understand first, you really need to understand what is addiction and what the use disorder is, because there are so many sort of criteria that you need to fulfill, and out of 10 you need 2 or so, and basically even with very minor issues you can label someone. But can cannabis as such, particularly high potency, lead to addiction? And theoretically, and looking at some of the data, as you point out, it's murky. It can, but like alcohol, it's important to understand most people who use cannabis do not develop an addiction. But there's a subset of cannabis users who can develop that addiction, or we call it cannabis use disorder, in which their frequent use can lead to what you call problems in multiple spheres of their lives, such as work, school, relationships. So I think the simple definition of addiction, which is repeated use despite harm. But I think we can also look at the DSM-5 definition, which is by tolerance, by withdrawal, symptoms such as anxiety or irritability, difficulty sleeping, and other host of psychosocial factors that are there. So I think, it involves issuing some of the responsibilities while using or pursuing cannabis. So estimates vary. I think you are very right that at one time it was 9% of the users sort of looking at for cannabis use disorder. But at the other end, it goes to 30%, in some people. And so it is such a wide variation. And for younger people, I think it's important. The proportion is slightly higher, which is about, if my memory serves me right, it's about 1 in 6, or about 17% young people who use cannabis, particularly the high potency, can develop cannabis use disorder. And from a clinical perspective, I have to say, though, the fact that only 1 in 6 will go on to develop, I don't think is comforting for especially the parents or clinicians, considering so many of the other things that can go wrong, particularly in adolescents and young people with hypotension.
Yes.
I think it's worth mentioning also the topic of gateway drug, which for many, many years was presented to the general public as marijuana is the gateway drug, when in fact there's no research to really back that up. Any drug could be a gateway drug. Any substance could be a gateway to substance abuse, and that's not really. It's a unfounded claim that marijuana is the problem.
Well, that sort of leads into the next question, which is an audience question submitted ahead of time. How do you create an intentional cannabis practice, and how is it possible to tell if someone will form an addiction or seek additional drugs as a follow-on? And Maureen, do you want to just start since we're already in your corner here?
Well, yeah, it's actually a good question for us at our clinic. I mean, it was established very intentionally to be specifically about serving the needs of patients. I mean, in Maryland, many of the larger institutions, the large university medical centers, they don't allow their providers to prescribe medical marijuana to patients, and it's simply not accepted. So the people who established our clinic, that was exactly the situation one of them was in. She is a gynecologist who works with a lot of patients who have pelvic floor disorders, and came to realize that medical marijuana was very helpful for her patients, but she was handcuffed, so to speak, by the institution. We tried really hard to provide the education that people need to help prevent some of the side effects, help reduce the likelihood of overuse. But we still see a lot of this. There's these patients who will come back again and again asking for increases in allotment. I think while we have the fears about older people not understanding how strong this is, my concern is more the younger people who don't understand the potential harm that's there. And really that's up to us as providers to educate them on an appropriate use and medical use. We know, for example, that excessive levels can actually worsen pain. And that's just one feature that we can try to explain to people. And we know that tolerance is a real thing that people will encounter. It's pretty normal. But a lot of our patients don't understand that. So the whole point of being intentional about this would be from the get-go, understanding that people need to learn a lot about this, even if they think they already know a great deal about it.
I think that health literacy is such a big concept around this. So health literacy is the ability that people have to find, interpret, and use health information. And with medical cannabis, it's been shrouded in so much misinformation, especially since the war on drugs. There's so much stigma around it. People just don't know very much, except they've heard in school that cannabis is bad. So it's very important. What I teach my students in my class, which is all about therapeutics, is that it's just like any other substance in a way, where we need to go over the evidence behind cannabis. We need to talk to people about what the strengths are of using cannabis and what are some of the limitations. We need to make sure that people are informed about side effects that they could experience, and that a monitoring plan is set up. And it's very important to screen people for things like cannabis use disorder. You want to make sure that you're quantifying how much cannabis is that person consuming, what type, how often are they becoming dependent on cannabis? Is it affecting other areas of their lives? So just like any other medication, we want to make sure that we're checking in on people and really monitoring them a lot. And I feel like that's a huge problem with the cannabis industry, where people get certifications and then they go off to the dispensaries. They might not get that knowledge that they need, and then they're out there on their own on the internet trying to interpret what is going on. So it's all about giving people that unbiased information so that they can make a decision one way or another about what's going to be the best for them, working with a provider who can help.
I think, believe it's important that this education be based on one's age. I think how adolescents perceive and understand is very different than how a 40, 50-year-old will understand the impact and what it means. And secondly, I think as clinicians, as mental health in different aspects, that we see a microcosm of people who are actually registered or using it. And I think if we have to make a difference overall, where, as they say, the best consumer is an educated consumer, I think the knowledge base has to, in some ways, be diversified. What do I mean? That it's not just, I think, from a science perspective, yes, I think it's our job. But I think at a more of a grassroots level, where people trust the information that's coming to them, they trust the people who are giving it to them. And that can be in schools, that can be in gyms, it can be in daycare centers, it could be at different places where people in their respective communities and leaders who can be given different sort of information and booklets and brochures and information that can be distributed widespread in the community at that level. I think it can go a long way, just like with smoking, it's been such a difference. And I think if we take that approach, in my opinion, and preemptively try to educate and do this, I think the therapeutic potential then will outweigh the potential risks in many ways, because we'll be able to educate people and there won't be a backlash as such of people running amok and becoming as psychotic with high THC.
And that's a really good point. I mean, I've run into this sense of quite a bit, and I see it on social media. We're up against the misinformation that's been given out for so many years in the war on drugs, that this is so dangerous. And as recently as 2 weeks ago, during a congressional hearing, one of the congressmen took the time to talk about the high rates of overdose death in this country. And as if that had anything to do with marijuana. So, we're running up against that kind of thing. How much trust is there for us if young people are hearing things that they know are just questionable?
So on this note, let's put it into some context. Dr. Ahmad, how much is biology and how much is environmental context? Help us understand some of that.
You mean in the context of cannabis use disorder?
Yes, correct.
Okay. So I think, the use disorder, as I think Tiffany has elaborated and has been discussed before, there's so much, number one, from the perspective of the plant as to what you are using, how frequently you're using, what you're predisposed to, what are your genetics in the first place. People who have a family history are more likely to become addicted. If it's being used at a high potency with high frequency, you're more likely to. And at the same time, your environment of the people you are with, and that makes a huge difference. But I think one needs to also take into account the comorbidities many times that exist. People who have been using other substances, for example, or using pharmaceuticals are addicted to them, are more likely to become addicted rather than somebody who's using other casual. And, going back to my history of why I became so interested in this, I think is an important point because it relates to what you are saying is working in an inner city hospital where you're seeing severe persistent mental illness, like schizophrenia or bipolar or other conditions, and heavy use, or even, if it's not heavy use, the use of cannabis, how their lives were impacted and how my training was, I just viewed through that very narrow lens to see, oh, this is causing this problem. And rather than an association, I was looking at a cause and effect relationship in that way. But what I started to in the last few years begin to, last decade, I should say, begin to see more affluent people coming from well-to-do places in my private office was, well, these people are using as well, but why aren't they struggling with the similar kinds of problems and issues that other patients are suffering that I'm seeing in my city? Many times the conditions are there. And I think that leads to that besides biology, I think the support systems and what people are struggling with is a lot to do with it, which leads to education, which leads to their resources, which leads to how compliant they are overall in that. So social context make a huge difference. I mean, there was a time when we thought of that the social environments led to mental illness. There's a huge data on that as well, which is, they can exacerbate, make it worse at times, but not the cause of it. So I think there is definitely biology, but social environment and context is extremely important because it can influence how much you use, how frequently you use, or what. And I'll share some interesting data with you. There was a study done, in fact, that people who were being released in New York from one of the prisons, no matter what people were trying to do with their mental illness, there was an acute exacerbation very soon afterwards they're released from the prison. And when they really looked at the data was that these people were being literally given one token for the subway and said, go out, and this is what you have. And these people would just get out, and as soon as they would get out, they would see people on the street and they would start smoking and doing this, and mental illness was not treated, or it would exacerbate or make it worse. And so this revolving door phenomena, I think a lot has to do with the social context versus, because if you see the prison population and mental illness and substance use, I think that speaks volumes about that.
It's interesting that I've seen so many patients in my practice who have PTSD after having been released from prison. And most of them didn't, they make it to our clinic and get some help, get referrals for mental health, that sort of thing. But this isn't happening, policy-wise, it's not happening where it should happen.
Because I don't think the resources are there. There was a study done out of VA in Austin on 68,000 veterans. It's a huge study. And they were comparing those patients to sort of other clinics, mostly private and other clinics, and looking at why are these patients relapsing so quickly and coming back versus the other ones. And one of the main things was that they were seeing was that the comorbid substance use was not addressed. There were not resources there. They were just like, okay, you're going to take your haldol-decanoate and that's about it, but no other pieces of the puzzle to prevent and protect them from, relapsing in that arena were put in place. So I think the social context and resources have a huge influence. And I think if we can make a difference there, and that's part of the education that we have been, I think, discussing, and I think which leads to policy making. And so I think they're all related.
Thank you, Dr. Ahmad. That actually helps us pivot nicely to research and Veterans Affairs. And Maureen, you'll be up first. So we had a question about whether the federal government's investing money in cannabis research. So I know there are some veterans bills out there that would do that. If you have any knowledge and would like to speak to that, but also if veterans cannot access opiates, are they being directed to cannabis? And how can folks transition from traditional pharmaceuticals to cannabinoids?
Well, the VA, like most systems, has been deliberately trying to reduce the use of opiates. Unfortunately, we often have patients who are on opiates long-term, and they have chronic pain. And we know that opiates are not the best way to treat chronic pain, but we didn't have a lot else to offer, particularly the VA. VA providers are not allowed to prescribe medical marijuana because VA providers are federal providers. They're not, they're under the federal umbrella, so they have to follow federal law. State laws don't get to trump that. So there's that block. I do know that they are not prevented from advising their patients to consider looking into medical marijuana. The VA people can't provide it or certify for it, that is. But there's nothing stops them from saying, well, yeah, if you're interested in this, why don't you go ahead and pursue it? That's another piece, I think, that can get lost in the shuffle at the VA. Legally speaking, people worry, oh, am I allowed to say these things? And you're not certifying anyone. You're not giving anyone marijuana. You're not doing anything against the law by simply talking with them about it. So what do you do when you've got patients who are on these high-level opiate doses and you're trying to wean them down? What are you going to, you take the crutch away, what are you going to give them to stand up with instead? Sometimes people find that medical marijuana can be a useful adjunct in weaning off of opiates. I've seen a lot of people successfully use other Suboxone, for example, but that doesn't mean that they can't also use medical marijuana as an adjunct. It certainly helps quite a bit with anxiety, and side effects of Suboxone can include some things like anxiety. If you can temper that with a high CBD product in order to help treat the anxiety, that's very effective. I have several patients who have successfully altogether gotten off of opiates, stopped several prescriptions, even more than just opiates, Lyrica, gabapentin, a lot of pain medications, simply by using medical marijuana responsibly. As far as research goes, I know that there are several organizations, veteran organizations, who have been pushing to change marijuana policy. There are certainly a need for that. The PTSD levels in veteran patients, there's a very high prevalence. And that's something that we know. There's no prescription FDA-approved drug that works on PTSD. So we don't have a lot to offer them. Talk therapy is nice, but it still doesn't do much to help people achieve any kind of improvement in a meaningful way. So using something like medical marijuana is a nice alternative. Other hallucinogens are being studied as well, and ideally the federal government policy would be towards the research would be able to include that.
Thank you. Kind of in the similar vein, I just read this really interesting study, and the way it was constructed was the researchers went in and they wanted to actually look at how people who were addicted to opioids were utilizing cannabis, and if they saw that there was a opioid kind of sparing effect there. So they did a series of interviews with people, and it's a really interesting study because they say that the sample size isn't representative of the general population, but they went into communities and figured out who was using opioids and talked with them. And some people did report that using cannabis did help decrease the amounts of opioids that they were using, and this is illicit opioid use. But this study really highlighted that there were a lot of other factors that come into play when people are deciding to utilize cannabis or opioids, and that addiction is very complex as well, because some of the people in the study were saying that when they go to a person who is a drug dealer, that there is a chance that they won't just get the cannabis in this situation, that they will get another substance as well. So I think it's really important to Now, obviously, there's a lot with the study that needs to be worked out, and it doesn't really tell us that much, but I think it's important to have this medical cannabis arena where people are getting good information, where they know about the products that they're getting, so they can go there and seek help as opposed to turning to alternative sources where then patients could be exposed to substances that have a higher addictive potential than cannabis.
Thank you. So I just want to give a brief reminder that we are in our last 15 minutes of this conversation. If anybody has any questions to be asking, please submit them. We've received a couple of fantastic ones. I'm going to just put it out there for the panel to discuss. There is a cannabis I'm not even going to say it properly.
Hyperemesis.
Hyperemesis, yeah.
Syndrome. Can you all describe this and discuss that syndrome for the audience, please?
Well, that's a condition that until very recently. Oh, sorry. Go ahead.
Go ahead. Fine.
I was merely going to comment. It's a condition that until recently most providers didn't even know about. It's something we weren't seeing. The only people who did seem to know about it were emergency room providers. But now a lot of people are hearing about it. It's becoming more common. And I think it relates back to the original discussion. Someone was talking about the rates of the amounts of marijuana, the potency of marijuana, and how much it's changed in the last decade or two.
And what
that seems to contribute.
Well, some regular users of cannabis can experience what we call as the cannabinoid hyperemesis syndrome, which is characterized by cyclic vomiting in the setting of high-dose cannabis use. That is frequently associated with, and these people, when they're having this effect, use compulsive hot baths or showers in order to control their symptoms. And believe it or not, they're looking at the numbers. I think it's close to 2.5 or 2.75 million Americans suffer from this cannabis hyperemesis syndrome each year. And the pathophysiology is sort of unclear, but the evidence suggests that there is sort of a dynamic relationship between the metabolism or the cannabinoid metabolism and the pharmacodynamics, which means how the cannabis goes and occupies the CB1 receptor and what it does to it. That's what pharmacodynamic means. So the CHS or hyperemesis syndrome is usually seen in the setting of chronic high potency cannabis use. And patients often describe taking this, compulsive bath. But fortunately, symptoms abate when users abstain from using cannabis. So, I wish we knew more about it, but more or less that's the basic premise of CHS.
And it's unclear, I've had some patients who've been diagnosed with it. Can they get back to using medical marijuana at a moderate or low dosing? That's unclear.
Yes and no, because we have had patients in the emergency room in the psych where they've had this, and some of them have gone back to and some actually have relapsed and came back within 24 to 48 hours back with similar symptoms. So I think whether it's genetics or whether it's the kind of cannabis or it's the potency or it's they have biological predisposition or going back to what we were talking about, all of the various components in the plant that are there and what ratios are there. Maybe that plays a role. I don't know, honestly. But I've seen relapse in people.
Yeah.
And now another audience question has just come in about, can you all, I know you're Dr. Ahmad and Maureen, you do a lot of direct clinical work, and Dr. Buckley more on the sort of academic side, but could you anticipate, what do we anticipate will occur with clinical research trials on medical cannabis? And what more randomized trials have you seen that you can either report on, or do you anticipate being conducted in the next 5 years, let's say? Dr. Buckley, do you want to start?
Yeah, so I can answer this one a little bit. So there are just so many restrictions with cannabis because it's still considered a Scheduled I controlled substance. That means right now that the federal government says that there's no accepted medical value and that there is a high potential for addiction. So in my classes, we go through all the latest literature constantly, and it's really hard to find cannabis studies that are randomized controlled trials. So a randomized controlled trial is going to occur when a researcher is going to get groups of people, they're going to mix them up, make sure they're mixed up equally, and then give that intervention of cannabis and give someone else nothing, and then watch what happens so that you can really kind of determine a cause and effect relationship. And in the cannabis-based literature, especially the area that I work in, which is mental health, a lot of that is really lacking just because of all these federal restrictions. There still is, there's issues with supply as well. So as Dr. Mahmood has mentioned, there was one place where researchers could get cannabis, and that was the University of Mississippi. And that cannabis potency does not match the potency that we see out in the communities. So not saying that that research isn't very valuable, because it still is, but it doesn't really reflect what's going on. So the DEA did make an announcement that they are going to open that up to more vendors soon so that other people can grow cannabis that can be used in clinical trials. So I think that until we are able to reschedule cannabis, there'll still be a lot of limitations with the research. I did see the CDC was just calling for research proposals, looking for information about social determinants of health and cannabis and opioids and other substances that are considered illicit, like alcohol. So hopefully research calls like that will mean that more research is done in the area, but that research too in itself seems to be focusing a little bit more on the harms as well as treatment instead of treatment. So what we're really interested in is treatment. So it's really important for us and people who are interested in medical cannabis to lobby and to try to get the scheduling of cannabis changed so that research can be opened up and we can truly figure out the benefit that is with this plant. I mean, people have been using it for so long for recreational as well as medicinal purposes. So there has to be some value there, but in order for us to truly find that out like scientists in a systematic way, there are going to have to be some changing of regulations in my opinion.
Thank you. Dr. Ahmad or Maureen, anything to add there?
Well, I think you've elaborated so well, eloquently, and I think it's like chasing our own tail, which is if you really want to have a discussion at the, for policy, it's data that leads to policy change. So when you go to have a discussion on the policy, the first thing is, well, show me the data. And it's like, well, there is no data. Well, why isn't there data? Well, because it's a Schedule I drug. Why is it a Schedule I drug? Well, because we haven't been able to show anything else because there's no clinical, as you pointed out, any studies done. So there are no clinical studies. There is no data. You can't reschedule it. You can't reschedule it because there is no data. It's just cyclical. And I think somebody needs to wake up and sort of realize you got to pick the cord at one end and try to make a change and a difference, because otherwise I don't see any potential change here. And I think we will continue to struggle on a state by state. I mean, if you look at the indications, there are total about 108 indications, but they're not 108 indications in every state. Every state has different, and every state comes up with its own formulation, and you can use it in this way and not that way. We are lucky in New York where it's like whatever the clinician feels is appropriate, you can use it in that rather than being subjected to a list of things in that way. But not every state is that way. So I think it's a very tough call to make right now, especially at the policy level, because data will not happen unless there is more clinical information, and clinicians have to jump through hoops at this stage. And it's very difficult unless you're in a huge academic institution with plenty of background and people helping you to do research on this.
Yes.
Largely the research on pharmaceuticals in this country is funded through pharmaceutical companies. I don't I don't anticipate them advocating or lobbying to make this research possible, because I don't see that they're going to really be able to take advantage of the opportunity.
Right, but you know, I don't want to put the companies that make money off marijuana on the spot. But needless to say, just like pharmaceutical, I think if companies are making good amount of profit, I think they have responsibility also to then give money for the research and to have some influence and do this. I mean, it's time to go give back to the community and to science if you are making money off it.
So, of course, we here at CFCR look to inform our government through the collection of data and research and studies so that we can make foundational decisions regarding the regulations of this industry. So we certainly support and look to gather the information that is out there. And certainly other countries have managed to do very, very many studies, not being bound by the same issues that we have here in the United States. So we are running out of time, but I would like to quickly do a round robin of each of the panelists with your 1 minute. Any last thoughts that you were not able to share during this conversation? Dr. Buckley, if we could start with you on sort of any wrap up you have.
Thanks so much for having us here today and listening. I think it's just important to know that the evidence around medical cannabis is murky, and we've talked about some of the limitations of that, but that doesn't mean that there isn't necessarily a therapeutic potential in cannabis. So we need to keep fighting to make sure that we can study it properly, but for patients that are using it now, it's important for them to understand the risk of cannabis and how limited the evidence is, but also know that there might be a benefit for them if they're utilizing it in a way that prevents harm.
Dr. Ahmad?
Well, to me, the most vulnerable and the population and upcoming is the adolescent and young people, because I think how they will react to this and with the policy changes and abundance of marijuana and being available is going to actually have a huge influence in legislation. And because if things are happening in the negative, it's not going to work out well. So I think it's imperative. I can't emphasize enough how it's a responsibility to educate them about the risks and benefits, and sort of partly biology, which is that the brain is developing until age 25. That's why if you look at the states, the so-called adult use, that's why it's called adult use. It's not just called use, recreational use. Is because, and 25, because the synaptic pruning, which is neuron sort of filtering and connections happening, continues to happen till that age. So the higher potency, particularly in families and with people who have predispositions specifically and frequent use, can lead to significant issues in this. And I'm not establishing a cause and effect here with psychotic disorders. Is there an association? There potentially is an association there, but it's the chicken and the egg story. Do people with SPMIs tend to sort of gravitate towards isolation and more drug use versus how these work as catalysts in that regard? But can it influence memory, concentration, and attention span, and executive impulse control, all of those things in young people? Yes, it can, absolutely. So I think it's a huge responsibility for us if we really want to make this and for millions of people who are struggling with all kinds of different ailments, I think my start would be there.
That's wonderful. Thank you. Ms. Fitzpatrick.
You know, I think it deserves to be mentioned, though it's not precisely about hype or health. The social justice aspect of the availability of marijuana. From a clinical perspective, that's a large reason why I feel it's important to practice here in Baltimore City. There's such an underserved population, specifically in regard to mental health issues. There's such a gap there, and particularly for young people. It's a tremendous gap for communities of color, and we can't ignore that. We can't keep lying to them about marijuana. Hearing that congressional testimony where someone was trying to draw a parallel between marijuana and overdose deaths, and then in the same breath tried to draw a parallel between marijuana industry and slave trade in the United States. These are the kind of things that are being said at the federal level in congressional hearings. It's such a broad topic. I appreciate it, but social justice has everything to do with what we're trying to accomplish without necessarily always realizing it.
Thank you, Maureen. Really appreciate all of our panelists today. We are wrapping up. Thank you for joining us today. Our next webinar will be Thursday, January 26th at 1 p.m. Eastern.
Wow, I cannot thank all of you enough for this wonderful conversation today and joining us for this. I want to thank you very much for this conversation around cannabis science, addiction, and misinformation. As Jack mentioned, our next webinar together will be Thursday, January 26th, and we'll have more information on our guests soon. Please keep your eye on our website, www.uscfcr.org, for more information. Also, a copy of our video will be on our YouTube site soon enough next week, so you can share it with anyone who is unable to attend. Again, you can find a copy of this on our website at uscfcr.org.
And thank you, everyone, for making this a big success. Could you please take a minute to complete a very brief survey as you exit? Thanks so much.
Thank you.